Okay, so let's just remind ourselves that what we have covered till date and what is, in the today's session. So basically, we started with the very first lecture, which was totally dedicated to introduction of the genomics and the personalized medicine concepts. Then we already understood the basic principles which are involved further in the genetic variations and the drug responses. Also, we have covered genomic testing and technology part. And then we already discussed some of the basic case studies and the genomic involvement into the basic case studies that covers the endocrinology, then the respiratory diseases and their genomics, gastro, and the neurological, right? So that those were the four very basic streams where the genomics plays an important role. And apart from that, we already understood the genomics in the drug development and regulatory affairs and the role of epigenetics. That was the last lecture. And we divided that particular common diseases, which involves the genetic mechanisms, into two basic lectures. And for today, the session is dedicated to complex cases. Okay, so earlier I already discussed with all of you that these are the very basic diseases which involved the genetic principles. And further in future, we have the complex cases too for the discussion, right? So basically, today session is dedicated to the genomic role into the rare and very complex diseases. That further includes the genetic influence on the some of the autoimmune conditions, that, example, rheumatoid arthritis, or the genomic involvement into some neurodegenerative diseases like Alzheimer's and Parkinson's. And also it is about the gene therapy and the CRISPR application. And also this is the very first part of the today's session, and the session is divided into the two basic parts. The second part of the session is that is dedicated further, that is challenges. Because when it comes to genetic testing, we all know that some of the ethical issues that arise, some of the complications are there to convince people. There is always cost is the challenge. So we'll discuss about what are the challenges in implementation of genetic testing in the community. So we'll discuss about challenges and also about the ethical consideration. Okay, so this is the two basic parts. 60-70% is the part 1, and the 25-30% is part 2. Okay, because ethical consideration are the miscellaneous things to discuss, but the important part here is genomic involvement into rare and complex diseases. Okay, that includes some of the autoimmune conditions like rheumatoid arthritis, and also some neurodegenerative conditions like Alzheimer's and Parkinson's. Okay, so that is the summary of the session. And we'll share the screen with all of you. So it will be very easy to understand once you fully understood the common diseases and their involvement, the genetic involvement into it. Okay, sharing this screen with all of you. Okay, so I hope the screen is visible. This is genomics and personalized medicine. I hope now the concept is clear in the head, like what is genomics and how it is involving into personalized medicine. And this is lecture number 7. Okay, that includes pharmacogenomics in the rare and the very complex diseases. And we'll see the second part, the ethical consideration into it. So, very first part we have, that is genomics in the rare and complex diseases. As learning objectives, we have three topics to discuss in the part 1. The very first topic is genetic influences on autoimmune condition. So we'll deeply discuss that how exactly the genomic is an important role here in the autoimmune diseases like rheumatoid arthritis, where the multiple genes are involved. Okay, second objective here is the neurodegenerative diseases, in which we'll discuss about the role of genomics in Alzheimer's and Parkinson's treatment as well. Okay, and the third will discuss the gene therapy and CRISPR application, which is, I think we discuss the name of this CRISP that in the second or the third lecture. But in today's session, we'll discuss in detail about what it is. The two types of the technique is there. So we'll discuss in detail about it. Okay, so the first part is divided into three basic subparts, that is autoimmune diseases involvement, neurodegenerative disease involvement, treatment, of course, and the therapy. Okay, so and CRISPR. And the second part is dedicated for challenges and ethical consideration in implementation of pharmacogenomics, in which we have four subtypes to discuss. Like, we'll discuss about the privacy and the genetic data security, because other countries, if you are aware, other countries are having certain kinds of software, certain kinds of apps, digital platforms for the security of data. Okay, we'll discuss why this genetic data is so sensitive. That is also the part of the discussion. So that is privacy. Second, we'll discuss about disparity in access to genomic testing. That is also the issue. Legal and ethical concerns in the genetic testing, and what is the important role of informed consent form, and the patient's autonomy. That is also our consideration, to know and not to know, right? The right of the patient, and genetic testing is a sensitive matter. So informed consent is also mandatory. So that is overall learning objective for the session. I think it is very understandable. And the important part here is the left side, that is the pharmacogenomics in rare and complex disease. So you will get to know that what are the genes which are involved in the treatment of rheumatoid arthritis, Alzheimer's, as well as Parkinson's, which are obviously, we have studied that there is no cure of Alzheimer, right? So once you know that what are the genetic mutations which are involved in the, which are further involved and which are triggering your parts like substantia nigra in case of Parkinson, and the tau protein which are in the, which is responsible and the cause of Alzheimer. So amyloid plaque is Alzheimer, and there is a genetic mutation, right? So, if you know that, the treatment approach will be very easy. Okay, so that is our overall aim and objective to study this whole topic. So let's get started with the very first part, that is the pharmacogenomics in the rare and complex diseases. And we'll start with the very first portion to understand in the part one. That is, we'll start again with the introduction. So that is a repetition of the definition. So the concept clarity is there. Make sure you know the definition now, because it is the seventh lecture. So I hope now I can expect that the definition and the goal is clear, right? So pharmacogenomics is the study of how an individual's genetic makeup affects the response of the drug. And it combines the two of the words, ecology, study of the drugs, and the genomics, study of the genes and their function. What is the role? The role is to achieve use of the drug, quality use of the medicine. When I say rational, it is all about right drug, right dose to the right patient at a right time with right cost. Okay, so minimizing impacts and the maximum efficacy is there. That is our primary goal behind genomics and personalized medicine. Okay. So that is the introduction. The second topic to discuss in a part one, that is application in a rare and complex disease. Okay, so we'll discuss about the rare diseases that often have a clear genetic basis, because we know that many of the rare conditions are there which involved a causative etiology, we can say, or causative mechanism that involves the genes into it, right? So there is a genetic mutation, is that there is a role of hereditary. So there are multiple conditions in which the genes play an important role. I think many of you might be having experience of writing, in exam, when the cause is about to ask, like पूछा जाता है कि what is the cause of diabetes, right? Etiology of diabetes. So ultimately what we have do, you can, we actually did it in the exams. सब कुछ लिखते हैं और बाद में lastly लिख देते हैं genetic cause. That was very simple to write, but it is having a huge mechanism behind it. Okay, so when we say a genetic cause is there in the disease, it means it can be treatable. It can be tested by the genomic testing, and it can be by certain technologies which is implicated further into the genomic studies, right? So we all know that the rare diseases often have the clear genetic basis and making them a very ideal candidates, the disease candidates for the genomic interventions further. For example, we have here the Fabry disease. Okay, Fabry disease or a Fabry, both of the pronunciations are there. So Fabry disease is also known as a Anderson Fabry disease, the AFD. Okay, this is a very rare genetic disorders if you know, and that further prevents the body from breaking down your fatty substances called lipids. So lipid breakdown is very mandatory in the body, and this disease is stopping further the genes basically which are responsible to breakdown of the lipids that are getting mutated in this particular condition. So this further result in what? Buildup of very fatty material in the cell, further causing many of the damages to the organs. And the reason behind this condition, the genetic involvement is there. So inherited mutation in the particular gene which is known as GLA, that is a particular gene which is getting mutated inheritantly located on a X chromosome, which are lead to the deficiency in the enzyme, which is called alpha GAL. Okay, so the genetic mutation is there, and ultimately, what happened? The enzyme which is made by the gene help, that enzyme known as alpha GAL, that is a galactosidase A. Okay, galactosidase A, the full form of GLA, that is in deficiency. So this GLA gene that is stands for the alpha galactosidase A, that is for making the enzyme alpha galactosidase A, which is an enzyme and the gene same name, which is very crucial for breaking down your specific sugar molecules in the body or a lipid molecules in the body. And this enzyme plays a role in recycling your cell components within the lysosomes as well. So imagine if this is not satisfactory in level, what will happen next? Okay, symptoms of Fabry disease, I can say the clinical presentations will be the numbness, tingling sensation, burning, or pain in the hands or feet, extreme pain during the physical activity, heat or cold intolerance, abnormal pattern of an eye that can be also seen in this condition, which doesn't affect generally the vision, and that can only be seen during an eye exam with a that slit lamp. Also, the dizziness is a symptom of the particular Fabry disease. You can observe symptoms are very simple, but cause is very big. Okay, the mutation here is the scenario, and that is the application. This is a very rare condition. Okay, this is the picture you can see here, the Fabry disease, which is a chromosome disease. GLA gene is getting mutated here. The full form here, now you have to remember the alpha GA is a alpha galactosidase A. Okay, that is a particular gene responsible to make a particular enzyme which is responsible for breakdown of your lipids. Okay, and it is not getting happen in the case of mutation. Symptoms you can see, diagnosis is only a genetic testing. Okay, so treatment we are having, we'll discuss later in the slides that what is the treatment. Basically, that is synthetic alpha gala is given here. Also there, but we'll discuss later so that more appropriately it can be delivered, right? So this is the application of how the genomic plays an important role here in a rare and a complex diseases like the Fabry. Okay, complex disease also includes rheumatoid arthritis, right? Alzheimer's, Parkinson's. Two of them are having neurodegenerative disease, Alzheimer and Parkinson, while RA is an autoimmune condition that involves multiple genes. Okay, in a bold it is written, multiple gene involvements is there, and some environment Okay, so complex diseases involves rheumatoid arthritis, Alzheimer's, and Parkinson's, and that is further involving a number of multiple genes and environmental triggers as well. Okay, so there is always multiple cause. Okay, and pharmacogenomics further helps with prediction who is more likely to develop the disease, either a gene or the environmental trigger. So once a patient go through the genetic testing, they might be more aware of the exact cause of the disease. Further, pharmacogenomics further helps to select the drugs that works best based on their genotypes. Okay, so which drug is more suitable? I think we had discussion on the patient might be having different category of rapid metabolizer, ultra rapid metabolizer, poor metabolizer. So based on the category, you can go for the dosage of the drugs. So selection of the drugs that works best as per their genotypes, genomic can help in that condition. And also it can help you to avoid certain side effects in the very vulnerable genetic subgroups, right? So that is also important, because once a patient is having a specific category like the ultra rapid or the poor metabolizer, there are higher chances of the side effect profile. Okay, so that is also can be avoided by the test of genomics. So that is the important role here. And for example, you can have here that ApoE4, that is the very important gene which is involved in the Alzheimer case, right? So that is particular the gene carries at the higher risk of Alzheimer, and that may respond differently to cholinesterase inhibitors like donepezil. Now this donepezil is a treatment approach of the Alzheimer, but some patient might be having a good response and some don't at all. So it is completely depend on the genetic mutations, right? So that is very important to understand. See here the ApoE4. See every body has a ApoE. Okay, but E4, E2, E3, those are the types of the APO which are involved in the different mechanisms. So that is very important to understand here. Okay, in further case we'll discuss in detail about this particular gene. So basically this diagram is showing you the two of the side where the ApoE associated Alzheimer disease you can see here. ApoE4 and the Alzheimer disease patients are suffering from deficiency or degeneration of the neurons. Deficiency basically happens with the tau protein. Tau, TAU. Tau protein is acting as a, uh, train, like supplying nutrition to continuously to your this area, right? And when degeneration happens because of the tau protein dysfunction or amyloid plaque, that is the second cause for the Alzheimer. The two of the condition like a tau protein we can say dysfunction and the amyloid plaque formation, both can degenerate your neuron further. Okay, so that is further affecting your verbal memory and visual memory. That is the affected regions, and these are the medial temporal lobe. You can see here the hippocampus and further the enterothecal cortex, to understand the region which is getting affected in case of Alzheimer's because of ApoE4, right? And some of the greater cognitive deficits are also can be seen here, because frontal lobe and parietal lobe is getting also affected. So executive function, yeah, and the visuospatial abilities and the language ability is also getting change in case of Alzheimer, depend on the patient itself. Okay, so this is the genetic involvement. So this is a brief contrast with the traditional pharmacology, because when it comes to the rare disease and to understand what is the involvement of genomics here, we need to understand what is the difference between pharmacology and traditional pharmacology and now the genomics. So basically, a traditional pharmacology is dealing with the aspect like approach, like that was the trial and error approach, and genomic here, which is recent, personalized approach, right? Traditional ecology, that is treating your population based on average response, while genomic based on individual. That is why it is personalized, right? Pharmacology on a one side, having the aspect of drug dose that is fixed or adjusted based on age and weight, while genomic further tailored by the genotype, like how the patient is going to respond. Okay, that is the important part. And side effect is the aspect, then traditional ecology monitored after prescribing, while pharmacogenomics predict before prescribing. Okay, predicts before prescribing that what will be the response. So that is the clear difference between traditional treatment and treatment with genomics. And that is the involvement of genomics into the rare and complex disease management. You can remember the difference so that the idea is, clear. Second topic to discuss here is the genetic influence. First, when it comes to the disease, that is the autoimmune disease we need to understand. Second part, but important part, started from here. The above part was, that was the introduction. Okay. And by this slide, we are dealing with the disease and the treatment. So, genetic influence on the autoimmune diseases, like focus is all about on a rheumatoid arthritis. See here, rheumatoid arthritis is a chronic systemic autoimmune disorders. We all know that primarily affects what? Joints. The immune system mistakenly attacked your synovium, that is the lining of the joints, causing pain, swelling, and the joint destruction as well. RA, that is rheumatoid arthritis, affects 1% of the global population with female predominance. Everyone is having that epidemiology, that females are more prone to further develop rheumatoid arthritis as compared to males, and onset typically in the middle age. The cause is multifactorial here. Okay, so there is no single cause of rheumatoid arthritis. There is involvement of genes, genetics, plus there is always involvement of environment as well, because of some other infections. Smoking is also a risk factor, right? So this is the introduction of rheumatoid arthritis. Let's see how genetic influence affects the treatment of it. We have two of the genetic risk factor here. Very first, for the in case of rheumatoid arthritis, we have HLA-DRB1 alleles. Okay, HLA, human leukocyte antigen, DRB1, that is the name of the allele. It is a shared epitome hypothesis. As I earlier said, hypothesis, that meaning multiple data is there to support the evidence. Okay, multiple data is there to support this evidence that this is the gene which is getting involved in the rheumatoid arthritis. Now understand what it is. This HLA-DRB1 is a gene within the MHC. MHC is a major histocompatibility complex, which is a region that further, encodes the proteins involved in the immune system. And it is associated with increased risk of various autoimmune diseases, this HLA-DRB1, right? Particularly rheumatoid arthritis. And these HLA-DRB1 alleles are numbered further with the 0401. Okay, 0401 being strongly associated with rheumatoid arthritis. So that is very important to understand that this gene is having direct connection with the development of rheumatoid arthritis. This gene encodes a part of the MSC class 2 molecules which presents the antigens to T cell. I hope you know what is MHC. As I earlier said, dendritic cells are there to catch your antigens. Then dendritic cells are presenting your antigen, working as a APC, antigen presenting cells, traveling through the lymph node and presentation occurs. Okay. और dendritic cell किसको present करता है? T cell को, right? Via MSC complex. And that's where this HLA gene that is having their role, right? Certain alleles like DRB104, 01, 10 that shares a common amino acid sequence that are known as shared epitome. And this sequence further increase susceptibility to autoimmunity by enhancing the overall immune recognition of self antigens. So they are identifying the own system as an foreign one, and they they start getting immune system activation. So that is the condition. You can see here HLA-DRB1SE that can triggered by the any kind of periodontal infections. Other genes like PTP and double two, that is 22, PTP and 22. This particular gene provides, I think I can have an introduction of the PTP and 2. Very important gene here because this gene, further provides instruction for creating a particular protein that is PTP. PTC stands for protein tyrosine phosphatase. Protein tyrosine phosphatase. If you are making notes, you can just make it, note it down that tyrosine phosphatase, that is very important. It is a protein. स्पेसिफिकली ऑन अ नॉन रिसेप्टर साइट पे ये प्रेजेंट होता है, एंड दिस प्रोटीन प्ले एन इंपॉर्टेंट रोल इन आई कैन से रेगुलेटिंग ओवरऑल इम्यून सेल एक्टिविटी, ओके, particularly T cells. Very important. And these are very crucial for fighting against infections. And this PTP and double two, that is a protein that help to control signaling pathway as well within your immune cells. Please remember, further it is influencing growth, division, specialization. Okay. Importantly, this variation in this PTP and double two gene that have been linked to an increased risk of certain autoimmune conditions like RA. Very, very important gene. Okay. PTP. I'm again repeating the name, protein tyrosine phosphatase. And again, some kind of environmental factors like smoking that can also trigger your HLA DRB1. Okay. And whatever presentation is happening to your T cell, that is getting transferred to B cell, and B cell again is responsible for making what? Antibodies, right? So that is how the immune system is getting activated, and the overall it is a useless activation, you can say, okay, resulting in autoimmune conditions. So this is the overall concept. See here, the second genetic variation which is affecting the rheumatoid arthritis. I think we already understood about what is PTP, protein tyrosine phosphatase, and double two that regulates your T cell activation. As I earlier said, mutations increase autoimmune risk. Next, we have STAT4. STAT4 gene encodes for the transcription factor. Okay, that is influencing a transcription factor further that play an important role in the immune response, particularly in the development and differentiation of the T helper cells, TH cells, okay, helper cells. And it is activated by certain cytokines which are involved further in regulating the expression of the genes which are related to further inflammation and immune responses. STAT4 influences cytokine signaling and immune responses. Okay, this is also the gene affects rheumatoid arthritis. Next, we have TRAF1, TRAF1C5. TRAF TRAF1C5, this is again a gene region associated with increased susceptibility to RA specifically and potentially other autoimmune conditions as well, especially a genetic variant within the region. As I earlier said, 53 number से end होता है इसका variant, that has been identified as influencing the risk of juvenile type of idiopathic arthritis. As I earlier said, idiopathic. What do you mean by the word idiopathic? Not known cause, right? Cause pata nahi hai, but still there is a case of a certain kind of arthritis. And if it is a juvenile, very important is a TREF1C5, implicated in inflammatory signaling and the joint damage. So this is, I think I have included the TREF image. You can see here TRAF. And if there is a mutation is happening with the other genes which are associated with the TREF, it will increase the TNF synthesis, tumor necrotic factor, tissue necrotic factor, okay, which is acting as signal for more autoimmunity. Okay, so that is very important to understand. So in rheumatoid arthritis, we have very important HLA DRB1, also some three miscellaneous PTP and double two, STAT4 and TRAF1. Okay, these are the genes to check in case of rheumatoid arthritis. Pharmacogenomic relevance क्या है? So RA treatment often includes what? DMARDs. I hope you know DMARDs. DMARD stands for disease modifying anti-rheumatic drugs, but not all the patients respond the same. Here's where genetics come in. Now let's see what is the difference. We have first treatment. As a treatment, we have very first methotrexate. Methotrexate is a first line agent, if you know. First line DMARD, disease modifying anti-rheumatic drug, works by inhibiting your folate metabolism. Shortly explain, like it is inhibiting folate. Genetic influence क्या है? If there is a MTHR FR, that is a methylene tetrahydrofolate reductase. The name itself has meaning. Methylene tetrahydrofolate reductase. Okay. So polymorphism affects further your folate cycle. Okay, and remember the methotrexate mechanism. It is working by inhibiting folate metabolism. Okay, so here is the variants C677T and A1298C. These two are the variants. You don't have to remember the variant name, don't worry. You just need to understand the basic mechanism, okay? So this particular variant, you can remember any of the variants is there, then it will reduce the overall your enzyme activity, okay? The enzyme. And if it is reducing, higher toxicity risk can be happen with the methotrexate. Okay, mouth ulcer, liver damage, that are the risks which can associated with treatment of rheumatoid arthritis. Also, we have SLCO1B1. I hope now you remember what is SLCO1B1. Transporter waste, right? So this is transport. Basically, gut cells से liver cells में transport करता है, right? Which are involved in the methotrexate transport in the liver cells. And if there is a variance, they may cause altered clearance and toxicity. So this is how the genomic play an important role in a very first line treatment of methotrexate as a DMARD. Okay. See here, second treatment we can go for rheumatoid arthritis, that is TNF alpha inhibitor. As earlier we can see, एक जीन था जिसकी वजह से RA हो रहा है, the TREF, right? TREF1 directly increase करता है what? TNF, right? So ultimately treatment क्या होगा? TNF inhibitor. We need to stop our immune system to work. So we are going for TNF inhibitors, for example, adalimumab or etanercept, right? So these are the very common drugs that can be used as a treatment approach of RA. Let's see what it is. Common biologics that are targeting your inflammatory cytokines, these two. Response variability is very high. Some patients respond dramatically very good, while others not at all. As I earlier said, right? Variant is there. FCGR3A, that is Fc gamma receptor 3A, polymorphism, meaning a variation, right? Mutation. V15-8F, that is affecting your binding of the drug to the antibody complex. Okay, now understand, in RA, when it is come to autoimmune condition, any of it apart from RA, your drug need to bind with your antibody to suppress it. Okay, so if the variant is present, this particular variant is present, this drug and antibody binding is not getting, appropriately. It is affect that binding. And the double V genotype, if the patient is having double V genotype, that is associated with a better clinical response. तो अगर आपके पास कोई पेशेंट है rheumatoid arthritis का और आपके पास जेनेटिक टेस्टिंग का रिजल्ट है, and if the patient is having double V genotype, you can blindly go for what? TNF alpha inhibitors, because the response will be good. Okay. And if there is a V15-8F, then your drug and antibody complex may be getting affected if you are using TNF alpha inhibitor in a treatment of rheumatoid arthritis. Okay. So that is the overall concept. Personalized dosing and drug choice strategies based on this, what we can do. So genotype guided therapy, that can be our major, drug choice. And that is helping us further to choice our better treatment, right? It is preventing toxicity, like it is associated with methotrexate, okay, and the variants which are associated with it, like a mouth ulcer and liver damage. Avoid trial and error with the biologics, which is a traditional treatment, right? Optimize cost effectiveness by predicting non-responders early. As I earlier said, if the patient is having a variant which is directly giving you the signal that they might be having, they may be having effect on drug and antibody complexes. So that is prediction of non-responders. So you can predict early and you can go for alternate agents. And what is the clinical relevance? So, Clinical Pharmacogenetic Implementation Consortium, CPIC guidelines, I hope now you know CPIC and PharmGKB is a database that is providing you further the dosing guidelines as well based on the gene variants. So, if the patient is having a specific gene, what can be the dose adjustment? Like if he or she is having a poor metabolizer category, so we need to reduce dose. If the ultra rapid one, we need to give a again apart based on the other situation, we can modify the dose, and this can be actually written in the CPIC guideline and farm JKB, right? So in the future, genetic panels may be done before prescribing to the guided treatments, and trust me, in the next upcoming 5 to 10 years this will be in practice for more personalized treatment. Okay, and by understanding this, I hope you are also having the idea that how this can be done. Okay. Okay, let's understand now. I think autoimmune condition is clear. Now, what let's understand genomics in neurodegenerative diseases, where we have two of diseases with which we can discuss Alzheimer as well as Parkinson. Let's first start with the Alzheimer. As I earlier said, the etiology of Alzheimer, tau protein and amyloid plaque are the two main cause behind the Alzheimer, and the reason behind this can be genetic, involves the genetic mechanism, and that is the gene involvement here, ApoE. So let's start with the definition. So AD, Alzheimer disease, is the most common form of the dementia, the memory loss, involving progressive memory loss and cognitive decline as well. Because the last stage of Alzheimer is a bedridden, right? So that is the Alzheimer. And the strongest known genetic risk factor is the ApoE gene. Particularly, as I earlier said, ApoE is there, but particularly E4 allele. Okay. So this ApoE, as I earlier said, apolipoprotein, the full form is apolipoprotein E, is a protein that plays significant role here with the risk of AD, development of the AD, with this E4 allele being the strongest genetic risk factor. Okay. And ApoE2 allele, if there, it is a potentially protective. Okay. So E2 is a protective, E4 is a very potent risk factor. So this is the two of the types, and ApoE is involved in lipid transport, metabolism, inflammation, and its different isoforms are also there, E2, E3, E4, that have again a different effects on the brain. Okay, that processes like amyloid beta aggregation, amyloid beta plaque, tau pathology, and the neuroinflammation. Okay, so see here, if one E4 allele is present, you have 3 to 4 times more increased risk of development of Alzheimer disease in the future. If 2 is present, 10 to 15 times chances are there, also associated with earlier onset. And E2 that may be protective while E3 is a neutral. You need to understand this. E2 variant is maybe protective and E3 is a neutral while E4 is a highest risk. Okay. So this is the Alzheimer disease profile. You can see here the types for your understanding. I have included that the ApoE gene play an important role here in the cholesterol and lipid transport, as I earlier said, and that increase the Alzheimer risk. You can see here the amyloid plaque formation and the tau protein uh, buildup. Okay. So these are the in some of the ApoE benefits are also there. APO2 जो है E4 E2 is the protection, and better visual working memory is also associated with it. E2 getting decreased risk, APO3, E3 is a neutral while E4 is increased. Okay, how can one prevent? So avoid certain disruptions, prioritize sleep, staying very active, good oral health, neuroinflammation prevention, checking for high homocysteine regularly, and some of the lithium orotate, microdose can be having a treatment approach. But trust me, we don't have any kind of specific treatment for Alzheimer nowadays. Donazepam is used, right? So ApoE type can be checked via the test, and some of the methods are also there to calculate the statistics behind it. Okay, so let's understand further. What is the drug response in the CYP2D6 mechanism in case of donepezil? So, cholinesterase inhibitors are the treatment of Alzheimer. For example, donepezil or rivastigmine. Rivastigmine is very important drug here. These are the first symptomatic, we can say, first symptomatic treatment of Alzheimer. And these drugs are metabolized by the CYP2D6, CYP2D6 in the liver enzyme. People can be poor, intermediate, and extensive or ultra rapid metabolizers depend on their CYP2D6 genotype. So if you are using donepezil in a same single dose, what will be happen, right? So we need to check the genotype of the patient first. If the poor metabolizer is there, that maybe the effect kya hoga, higher blood level will be there, risk of side effects, and trust me, rivastigmine donepezil comes with a very large huge side effect profile. And if the patient is having ultra rapid, you need to lower the drug level of, that is further reducing the efficacy. So that will be the effect based on the category of the people. So what is the clinical implication? CYP2D6 testing before giving any kind of cholinesterase inhibitor in case of Alzheimer. क्या करना चाहिए? CYP2D6 testing that can optimize your dosage calculation. Very, very important. Okay. Okay. Third option for the treatment approach in the Alzheimer is a memantine, and memantine has direct relation with the glutamatergic genes. Okay, very important here. Memantine is used in moderate to severe condition of Alzheimer's, and it is blocking your NMDA receptors to regulate your glutamate toxicity. One single line is there for the understanding of mechanism. We are not understanding ecology here, so I'm not getting in very detail, but I hope it is making sense that if you are using memantine is having direct relation to block your NMDA receptor. Further, it is regulating your glutamate toxicity. Glutamate से जो toxicity होती है, that can be regulated by blocking NMDA receptors. Okay, research is exploring how this green, which is GRIN, this is glutamate receptor genes and other synaptic plasticity genes may influence your response to memantine. If you are having a variation in particular condition in green like genes, then it will be having a reduced efficacy or increased side effects of memantine respectively. So it is still emerging but may explain the variability in outcomes. Okay, see here the history of the memantine. It is from the 1966 2018. Memantine is used in the Alzheimer disease like moderate to severe and some other conditions as well like a vascular dementia. So combination therapy is also there. Comparison with the other drugs are also happening nowadays. But it is a classic treatment for Alzheimer disease. So we need to check the genetic mutations which are associated with the green genes, GRIN, if you are using memantine. Okay. So this is how it is having a link of genetic testing with the treatment. Precision trials and the polygenic risk factors we need to understand in case of Alzheimer. So what do you mean by the polygenic risk scores? Polygenic risk scores PRS एक tool है which is a tool that can be used in the genetics to estimate an individual's risk of developing a particular disease. Okay, or you can simply say it is a trait based on the genetic makeup. So it is a statistical calculation ultimately that considers the combined effect of many common genetic variation or variants across the overall genome. Okay, so that is the definition of polygenic risk scores, that is use of multiple gene variants to estimate your developing AD risk. Used in the clinical trials to enrich the populations likely to progress, making trials more efficient. And it further helps to target preventive therapies before the symptoms actually starts. This is how it can, calculate. So it is basically a statistical way of calculating your genetic variants. ओके, पोलीजेनिक रिस्क स्कोर्स दिखाएगा कि आपको फ्यूचर में अल्जाइमर होने की शक्यताएं कितनी है, राइट? पॉसिबिलिटी ऑफ हैविंग अल्जाइमर इन द फ्यूचर यू कैन आइडेंटिफाई बाय पोलीजेनिक रिस्क स्कोर्स. So the term should be, you should be aware of the term polygenic risk scores. Okay. Okay, so now it is Parkinson's. So, the very key genetic mutations in the Parkinson. Let's understand. Parkinson is also the neurodegenerative disease characterized by, I hope you know, dopamine neuron loss in the substantia nigra, right? The portion which is getting affected in the CNS because the synthesis of dopamine, okay, the source of the dopamine is substantia nigra, and in which dopamine neuron is getting lost, neurodegenerative disease, degeneration of neurons is happening. So ultimately हम इसमें क्या देते हैं, लीवोडोपा, राइट? सो बेसिकली डोपामिन न्यूरॉन लॉस होता है, दैट इज द अल्टीमेट etiology of the Parkinson, and genetic forms are involved here. Tremor is the very popular symptom of the Parkinson's. So genetic forms of the PD that helps to understand the disease further, and you can see here many of the genes are involved in the Parkinson development. So very first we have LRR K2, which is the most common in the familial and the sporadic cases. Because when it comes to Parkinson, we have types: familial, sporadic, right? Typical. So these are the types. Based on the etiology, based on the pathology, it can be characterized. So first have LRRK2, the most common one. Then SNCA. SNCA is again a very popular gene mutation, alpha synuclein gene, which is forming a Lewy body. Lewy body is one of the etiologies to further decrease the dopamine into the substantia nigra. So the neuron loss is there. associated with the Lewy bodies. Okay, and one of the genes which is responsible to form it, SNCA. Next, PARK7, the name itself has meaning. It is directly associated with it, also known as DJ1, that protects against the oxidative stress at a somewhat level, but it is also influencing the disease. Okay, GBA is also there. I hope you know the GBA, because GBA1 gene, which encodes for the lysosomal enzyme glycocerebrosidase. Okay, these are a very significant risk factor for PD, Parkinson disease. So GBA mutations are the most common genetic abnormality which is associated with PD, and GBA mutations which are most common one in the Parkinson and can impact the effectiveness of dopaminergic medications as well. So if you are using levodopa, this GBA mutations you need to check, because it is having direct relation with the efficacy. Okay, the link between this mutation and dopaminergic drug toxicity is multifaceted. Okay, and involving both direct effect on the neurons and indirect effects which are related to lysosomal dysfunctions as well. So I hope you know the GBA very well. If you have understood the Parkinson disease, you may have idea. But if not, do not worry. You just need to understand that GBA has direct relation if you are using any kind of dopaminergic drugs in case of PD. You need to check this. Okay. So it can increase the PD risk and the severity. Let's understand the relation with the treatment. So, drug metabolism, which is focus on the levodopa and COMT, which is very important to understand. So, levodopa is the gold standard treatment, as I earlier said, because we need to uh, main focus of R is on the dopamine, and it is getting decreased in the Parkinson, so we have to administer. Okay, levodopa is nothing but a dopamine, right? Gold standard treatment metabolized by the COMT, catechol O methyltransferase enzyme. So in case of this COMT, well 158 mat polymorphism, that is a variant that makes a people in a two most category, any of the one, that if the patient is having VLVL, that is a higher COMT activity. So the faster levodopa breakdown will be there. So lower levels of the dopamine can be achieved, as it is not as expected. So the treatment efficacy will be low in that case. Or there is a MET that is making a person under the category of slower breakdown. So there will be a higher levodopa levels. So in that case, we need to reduce dose because the breakdown is slow, right? So you need to check COMT if you are going with the levodopa, right? Also the GBA, right? So what is the implication? So in case of VLVL, patient may need higher dose or the COMT inhibitors as as a treatment adjuvant, right? Therapy adjuvant. So हमारे पास वो भी है, COMT inhibitor भी है. So if you are introducing levodopa and the patient is having a VLVL category, so patient को क्या चाहिए होगा? Higher dose, because fast breakdown होता है. उसके साथ अगर आप जा सकते हो तो COMT inhibitor, right? So दोनों में से एक चीज you can choose. And if the patient is having MET, that patient may be more prone to dyskinesia, because टॉक्सिसिटी होगी उसमें, स्लो ब्रेकडाउन है, और अगर आप आइडियल डोज के साथ जाओगे, सो यू आर गोइंग फॉर ट्वाइस अ डे और एनी काइंड ऑफ स्टैंडर्ड ड्यूरेशन you are maintaining, but the patient is slower in nature of breakdown, then higher levodopa will be there, risk will be there for dyskinesia, involuntary jerks will be there. So बहुत बार देखा है कि लिवोडोपा कंटिन्यू है फिर भी पेशेंट इज सफरिंग फ्रॉम इनवॉलंटरी मूवमेंट्स, ट्रीटमेंट फेलियर का केस बन जाता है, बट इट इज नॉट because of the lack of treatment. It is based on genetic profile. Okay, so I hope now it is making sense. Very important. GBA mutation and dopaminergic drug toxicity, you need to understand. GBA mutation carries further very severe cognitive symptoms like greater sensitivity to this kind of particular drugs. These are having higher risk of hallucination and confusions. So this also need to check, need to be checked before prescribing any kind of dopaminergic drug. Genotype informed prescribing that may avoid, early cognitive decline triggered by the medication. So if you are checking the genotype, you can further reduce this kind of the side effects. So this is the GBA. You can see here the mutant GBA दिखाया गया है, so that you can understand that it might lead to the C case deficiency. Further it will inducing your alpha synuclein aggregation responsible for generation of Lewy bodies. Okay, altered your lipid homeostasis, autophagy, lysosomal dysfunction, and mitochondrial dysfunction. Ultimately, everything is leading to neurodegeneration. Okay, so this is the case. Future direction क्या है? Genotype guided neuroprotective strategies you can implement, like tailoring the drug regimens based on mutation status and disease subtypes, like it is a tremor dominant or a cognitive heavy. Okay, so which is the symptom, like what is the subtype of the condition? Use of gene targeted therapies like antisense oligonucleotides. I hope you have this the minor idea about antisense oligonucleotide therapy. So basically it is written as ASOS. Okay, antisense oligonucleotides. These are a very promising therapeutic approach for Parkinson disease. If you don't know, gene targeted therapy hai ye, or very promising it is, particularly targeting your alpha synuclein, which is responsible for Lewy body synthesis, and it is a key protein involved in the disease progression, right? So this antisense oligonucleotides can further modify the production of a specific protein, and which is further binding by the mRNA, potentially slowing or halting, you can say, the disease progression. Okay, and this is very promising. Reducing overall your alpha synuclein, right? Which is in the animal models is also there. The trials are also there, and this is very promising in clinical trials. So gene targeted therapy like this is very important. And integration. This is again a treatment approach of multi-omics. You can go for genomic profile, proteomics, metabolomics for comprehensive profile to understand what is suitable and personalized treatment for an individual. Okay, so this is the overall treatment approach. So let's understand the fourth topic of the part one, that is gene therapy and CRISPR application in a complex disease. Very important again. So CRISPR Cas9, so no, Cas9 is a revolutionary gene editing. Now this is having a two types, in vivo and like ex vivo and in vivo. So we'll understand how it is, but basically what it is, इसमें क्या है, डीएनए सेगमेंट को कट करना है, वॉट एवर यू डोंट वांट, and whatever you want can be inserted. Okay, that is the simplest mechanism. The full form is here given here, that is the clustered regularly interspace short palindromic repeats. Okay, very big name, complicated name it is, but ultimately it is known as the CRISPR or the CRISPR. And here the Cas9, that is a DNA cutting enzyme, the nuclease. Okay, Cas9. Okay, so see here, basically clustered regularly interspace short palindromic repeats. That is the full form of this, and it is basically, you can see here the Caesar. So basically cutting down your unwanted portion and reinserting it further. That is the basic technique. Okay, let's understand further how it works. So it is guide RNA, that is the gRNA, which is designed to match your DNA sequence to be edited. And this Cas9 use the enzyme, the guide, to locate and cut your targeted DNA fragment. Cell repairs the break, like knock out the gene, disrupting a function, and insert or correct a gene using a repair template, as I earlier said. So you can see here the picture, जो आपको नहीं चाहिए वो आप eliminate कर रहे हो, cut कर रहे हो, or you are inserting something which is editing, okay, edited. So that is the overall concept. We have two types, ex vivo and in vivo. What is ex vivo? Cells are removed. See here, gene therapy types. We have ex vivo versus in vivo. Ex vivo therapy. Cells are removed from the patient, genetically modified in the lab, reinfused into the body. That is ex vivo. Okay. Advantage, more control over editing because it is in the lab. Testing before infusion can be happen because it is in a lab. Okay. Used in a blood disorders like the sickle cell. Very important. See here the definition or the overall picture. So it will be having more idea. Ex vivo, right side pe hai, gene inserted, transferred into patient cell by viral or non-viral methods. And that is basically in a lab. Okay. Modified cell re-injected to the patient. That is gene therapy. ओके, एंड इन वीवो क्या है? इन वीवो अगर हम समझे थोड़ा डिटेल में, तो इन वीवो जो है, दैट इज अ जीन एडिटिंग, occurs directly inside the body, like it is not in a lab. using vectors like often viral, okay, delivered through the injection or infusion, and it is used in the eye disorders, liver, and the muscle diseases. See, this is the in vivo technique. Case 9 को थोड़ा zoom करके दिखाया गया है, the enzyme which is responsible to cut down. So this is basically inside the body, okay, and ex vivo is in a lab, okay. So that is the overall CRISPR system. Ex vivo is very popular for sickle cell and CAR T cells. Okay. And in vivo is responsible for Leber's congenital amaurosis. That is a condition, very important condition to understand. And control is, you can see here, the ex vivo has a high control, while the in vivo has a low control because it is inside the body. Okay. So if I can say delivery, you can see here the lab based and the direct injection is given. And there's LCA, that is a Leber's congenital amaurosis, that is a rare inherited eye disease that appears at a birth, okay, or in the first very few months of life. Eye disease it is. So as I earlier said, in vivo is very effective in the eye disease. I hope it is, the now the types of the gene therapy clear. See the basic difference. Ex vivo, you can see here the pattern dish, so it is a lab based. And in vivo, you can see here the viral vector is there, and it is injection like IVIT, right? IM. So it is inside the human body. So real world examples also we are having, like a sickle cell के लिए हमारे पास CRISPR है, that is editing of BCL11A, important gene for sickle cell. Mutation in HBB gene that is causing a malformed hemoglobin, and that is what sickle cell, right? The shape is getting changed. CRISPR is used to turn off this BCL11A mutation, a gene that repress your fetal hemoglobin and increase your HbF, compensates for defective adult hemoglobin. So that is a very good example to understand, real world example जिसमें ये technique gene therapy use हो रही है. You can see the schematic presentation where the adult hemoglobin gene that is being seen, and the normal adult hemoglobin. But when it comes to BCL11A gene, so you need to go for what? CRISP, Cas9, fetal hemoglobin में convert करेगा, right? So fetal hemoglobin में convert अगर हो जाएगा, then it will be less chance of developing sickle cell. So that is a real world example. Also, we have second example of this LCA, rare eye disorders, Leber congenital amaurosis, eye disorder, inherited retinal disease. It is childhood blindness बोलते हैं इसको. First, in vivo it is inside the body. When it comes to eye, in vivo technique होती है. That is edit 101 targets further the particular gene CP290 mutation injected directly into the eye, safe and promising early results देता है ये. You can see here the different genes of on which the gene therapy has been performed. Okay, so this is how the real world examples are practicing CRISPR Cas9 as a gene therapy. So what is the hope for autoimmune and neurodegenerative disease? Silencing mutant gene in Parkinson's, like it can target SNCA gene like alpha synuclein to reduce toxin protein accumulation. Also, you can go for CRISP, that is used to downregulate your gene expression instead of cutting it directly. Okay, and editing in immune checkpoint in the RA, like modifying your T cell macrophages to suppress the inflammation and potentially target genes like TNFA, interleukin 6, or enhancing the overall CTLA4 pathways. So that is very important. These are the hopes for autoimmune and neurodegenerative disease in case of genomics. Okay. What are the challenges? Challenges are very easily understandable. So first challenge is delivery system. Like if I can say gene therapy pe jana hai, so viral vectors are there. Okay, that is a challenge. That is a difficult task to do. Nanoparticles needed to deliver the genes, but each has their own limit, like its size, immune response. Also, off-target effect is a challenge. So we have CRISPR that might cut unintended DNA. So risk for mutations, cancer, immune reactions like body may recognize the vector or Cas9 as a foreign material, trigger the immune attack as well. So hypersensitivity भी हो सकती है. Cost, of course, is the biggest challenge. Gene therapy cost greater than you can see a $1 million, not yet scalable globally. So a normal patient who is having a a middle class people who is having genetic mutation, they cannot afford a gene therapy, but it is existing. In future, you can have hope for effective costs as well, right? Okay, let's move forward with the part two of the session, challenges and ethical consideration in genomics. Very important to understand here the privacy and the genetic data security. Why is genetic data sensitive? Your DNA is very unique. Everyone has idea, permanent and traceable to you, even when anonymized, right? So even a small gene panels like a pharmacogenomic test that can potentially be re-identified as well. So इसके गलत यूज होने के चांसेस बहुत ज्यादा बढ़ जाते हैं, right? Misuse. Let's understand what are the risks. Data breaches, leaks, or hacking of genetic database, misuse by the third parties for profiling or commercial exploitation. Long-term implications like your data may be used decades later if you are not there, right? So solutions, what are the solutions of data security? Data anonymization is the very first part, like encryption and access control. You can see here in HIPAA, okay, HIPAA is in USA, very important health data privacy के लिए उनके पास है Health Insurance Portability and Accountability Act, HIPPA, okay, that is Health Insurance Portability and Accountability Act, which is in USA, which is secured the genetic profile and the data. Also in other European Union countries, like they are having a GDPR. GDPR is a General Data Protection Regulation. General Data Protection Regulation, okay, that is a consent driven data protection. Consent ke bina it is not getting opened. So role of biobank governance, audit trails and ethical review boards, very important. HIPAA is very important. General data protection regulation, very important. Other countries are having it, right? So if you are going for it on a large scale data, if you are getting, you need to have this for protection. Disparities in access to genomics. So, what are the key barriers here? High testing cost, often not covered by the insurance. Okay, genetic का एक बहुत बड़ा ये है कि बहुत बार ये risk होता है that if the patient is having a specific mutation, insurance won't be covered, right? So that is also the very important thing. Limited lab infrastructure in the low and middle income countries like us. Urban versus rural divide. That is testing centers mostly in the metro areas, so rural areas subside ho jata hai, and that is also risky. What is the impact? So widening these health in inequalities, that is some populations get the personalized treatment, others don't, okay, and skewed data, that is under representation of non-European asymmetry in the genomic databases, so that might be resulting in less accurate results for them. I think these are the very self-explanatory things that we all can be agree with these points, right? Yeah, this is the thing, these are the impacts, these are the key barriers we can assume and we can understand disparities. What is the solution? So, inclusion of genomics in the national healthcare policies very important. Subsidize the testing programs. Public-private partnership should be there. Mobile labs, sample collection kits, digital reporting in the rural areas. This might be solutions. Okay, but let me tell you, these are very simple to say and simple to understand. But when it comes to implementation, very hard, very challenging. Okay, so these are the things. What are the legal and ethical concerns in the genetic testing? So, genetic discrimination is there. Like people may fear that insurance companies or employers might use the genetic information to deny the coverage or the jobs. You can see the example like you have a gene that increase Alzheimer risk, so we can't insure you. This might be the case scenarios, right? If everything is getting leaked. What is the legal protection? So you can have idea that there is an act like GINA, that is the Genetic Information Non-Discrimination Act in the USA, that protects against such misuse. So ऐसा ना हो इसके लिए भी protection act बनाने पड़ते हैं, right? So we already have, like USA already has it like GINA, and many countries lack this clear law and the enforceability. That is the biggest challenge, legal challenge. What are the gene patents and the commercialization? So companies once tried to patent the human genes, like the BRCA is already patent. Legal battles in the US it is, like ethical concerns are there. Limit access, drives up cost, and treats the genes as corporate property. That is also the biggest issue. Okay, market में ऐसे भी लोग हैं so they are treating genes as a corporate property. This is above our imagination, right? So, informed consent and patient autonomy is very important. What is the challenge? Genetic literacy is very low. So, many patients don't understand the risk, the penetrance and the inheritance. So, information may be overwhelming and misinterpreted, especially when the results don't mean the disease certainty. That can be happen. Simple hypertension के बारे में counseling करते हैं तभी हम ये चीज observe करते हैं, then it is the genetic, right? So, it is very hard to convince people and let them know that what exactly the meaning is, right? Right to know versus right not to know, very important. Some patients may not want to know about the future risk. In your household also you can practice, some of our parents are having, they are used to say that vahem ho jate hai, right? So some patients may not want to know about the future risk, like the Alzheimer with the ApoE4. So ethically, patient have right to access their data, and patient has right to refuse testing as well. So we cannot force someone, but this is the things. Ethically, these are the right concepts. Best practice, culturally sensitive communication. Very important. Consider whatever language, beliefs, and stigma they are having. Use genetic counselors to explain results and options. As I earlier said, genetic counselor is a post, okay, which is very important. Respect family implications while preserving the individual's autonomy. That is the best practice one can do. Okay, simple to understand. So, the final summary of the session is pharmacogenomics promise your personalized medicine, but its ethical success depends on how we protect privacy, ensures equity, uphold consent, and navigate further the gray zones of legal and moral responsibility. So that's what the genomic has lots and lots of concepts to understand further. So this is the final summary. What are the points to take home, guys? The very first part, we have understood the genomics in a very rare and complex disease like autoimmune conditions, rheumatoid arthritis, genes associated with the treatment, methotrexate के साथ क्या है, right? वो हमने देखा. And next we have seen the neurodegenerative diseases in the part one, Alzheimer and Parkinson, genes and the treatment. Secondly, we have understood the challenges and ethical consideration in the genomics. So these are the points to take home. Okay. So that is the end of the session. I hope it is fruitful enough, because this is very important in when it comes to the rare conditions. Just keep. If you have any question, you can simply put into the chat box or just unmute yourself so that we can discuss further. I think there is no question. Okay, just a gentle reminder that if you are having in future any kind of question, you can simply put into the WhatsApp chat box. I think two more lectures to go and we'll complete the basic course on the genomics. So again, I would like to remind that you will be having exam, okay, after the completion of course. Also, your attendance is very important to get the certificate. Okay, if there is no question, we can left. Okay, thank you guys for joining. Okay. તેનો ભૂખ લાગે ને નાસ્તો ક્યાં મૂક્યો છે એ બી તને ખબર નથી ઘરમાં પણ મારે ભૂખ જ નહીં લાગે લાગી જ હોય લાગે તો મેં નાખો ક્યાં મૂક્યો છે નાસ્તો બધે નાસ્તો ક્યાં મૂક્યો છે નાસ્તો ક્યાં મૂક્યો હું તો ભૂખ લાગે લાગી જ હોય નાસ્તો ક્યાં મૂક્યો છે તેનો મારીશ તો અહીંયા અંદર બધા મોટા